Hello everyone, welcome to FLIC's online learning event, Misunderstood and Overlooked. My name is Alison, I'm the Programme Manager for Fulfilling Lives in Islington and Camden. We can't see you and you can just see us, but I just want to say thank you so much for joining us today. We're so excited there's so many people joining us and we're really excited to give this event today. So a little bit of housekeeping as people join. The event, as you will see, is being recorded today. If you'd like to tweet, please do so. The hashtag is on the screen in front of you. Hashtag misunderstood and overlooked and tag in FLIC. It would be fantastic if people could introduce yourselves in the chat box, which is the little voice bubble at the bottom of your screen. And if you have any questions, we'll have plenty of time at the end of the event for your questions. So please do add your questions in the question answer box, which is the two little speech bubbles at the bottom of your screen. Just a note, we're not expecting any IT disasters today, but please bear with us if we have any little IT glitches. Just to give you an introduction to Fulfilling Lives Islington and Camden. FLIC is funded by the National Lottery Community Fund, and we are funded to look at how the system supports people experiencing multiple disadvantage. And by that we mean people experiencing mental health issues, homelessness, substance misuse, domestic violence and abuse, and also contact with the criminal justice system. And we're really interested in finding new ways to address some of these issues. And wound care and leg ulceration is a massive issue that affects so many of our clients. Many of our clients, unfortunately, have lost limbs, have had limbs amputated because of these issues, and many more are at risk of having that happening. So we really wanted to try and find a way forward with these issues. And from that, our wound care pilot began. So just to tell you a little bit about who you'll hear from today, you have it on the screen in front of you. We are very excited to be joined by Right Honourable Anne Clwyd, who has been an MP for 35 years and has always been a long time passionate campaigner for better health. We're joined in film by Ian, who's a client of our Camden Islington Navigator service, and Ian speaks really movingly about the impact of leg ulcers on himself and the pain and the stigma that that brings with him. We'll hear from Jasmine Malik, who is a GP and homeless healthcare specialist, who will talk about why we really need to address this issue, why we'll talk about the impact both from a human perspective and the impact on the system and the financial impact if we don't get this right. And we'll also hear from Deborah Holt, who's an Assistant Director of Integrated Commissioning in Camden. And Debbie will be speaking about the challenges and the opportunities of commissioning for homelessness health. And we will also hear from Dr. Lukla Biazi, who is a vascular and endovascular surgeon at St. Thomas's and King's Hospital. And Dr. Biazi will be giving a really invaluable perspective on the consultant's view of how it is when clients come into hospital in acute care and in acute crisis. And last but by no means least, we'll be hearing from Dr. Jamel Geraghty, who's a tissue viability nurse and King's College lecturer. And Jamel will be talking us through our wound care and leg ulceration pilot and talking about the learnings, our reflections and our recommendations from the pilot. And at the end of that, there'll be plenty of time for our questions. Just a note on the content of the slides. We will be sharing on a small number of the slides some pictures of leg ulceration, and obviously this is not something we do lightly. We did think whether or not to do this. We think it's really important to bring these issues out into the open, and these are issues that are too often hidden away and people don't want to see. So we felt it was really important to address that. And Jamel will give us, will let us know before she's sharing the images. But we think, although these images are hard to see, they're obviously even harder to live with. So it's really important we address that. So as you can tell, we've got a very packed agenda. So I'm now going to hand over to Anne Clwyd. So it gives me great pleasure to introduce Anne. So over to you, Anne. Thank you.
Hello, Alison, and whoever else is listening. I'm very pleased you asked me to come back today because I feel very strongly about this issue. I developed a small farthing size ulcer on my leg. I didn't know it was an ulcer even, but it was a sore patch. And I asked my chiropodist, what is it? And she said, well, I'm not sure. And then I went to her a month later and I said, it doesn't look any better. And she said, you better ask your GP. So I asked the GP, who is a very good GP on all the issues that I've consulted her on over the years. But on this particular one, she said, I'm not sure, you better go and see a consultant. So eventually I got to see a dermatologist, and who also looked at the same thing and said, well, I'm not sure what it is. Well, by this time I was getting really worried. And I said, well, what am I supposed to do? It's getting bigger and it's sore. And he said, try Vaseline. Well, it turned out to be something that couldn't be treated by Vaseline. And luckily at that time I was opposite St. Thomas's Hospital, and I was able to go in there and be properly diagnosed, and I was told that I had a leg ulcer. Now, I should say that during this time, it was beginning to hurt quite a lot. And indeed, as time went on, I found it very sore indeed. And then somebody else gave me some Manuka honey to put on it. Now, for some people, Manuka honey, I'm told, is okay. But for other people, you can be allergic to it. And I was clearly allergic to it. And the next thing that happened, actually, before I went to St. Thomas's, I was in my own constituency. And I went there for a meeting with a group of men. And I said, I'm really sorry, I can't speak today, which they thought was very odd. And it turned out that I was so bad that the paramedics were called and I was taken to the local hospital, where again, they were a bit vague about what kind of injury it was. But anyway, I eventually got diagnosed properly, treated properly in St. Thomas's, with, of course, the experts on the job. But I really can't forget how painful the whole thing was. I mean, I've had various, luckily, relatively small illnesses in the past, but actually to have the kind of pain I had with the leg ulcer was indescribable. I remember the paramedic asking me at the time, what level would you put the pain at, 1 to 10? Well, I don't usually exaggerate, but I said on this occasion, 9. That's how painful it was. And so I feel very strongly that, the right resources should be put into dealing with leg wounds, because I think wound care should be seen as a specialist segment of healthcare that requires clinicians with specialist training to diagnose and manage. You know, a lot of money is spent in the NHS on dealing with supposedly dealing with leg wounds. They say there's something like 2 million patients are treated for wounds every year. It's a cost of more than £5 billion to the health service. And while something like 60% of all wounds heal within a year, a huge resource has to be transmitted to managing untreated wounds. And I think the NHS response is variable. Healing takes far too long. Diagnosis is not good enough. And obviously there's inadequate commissioning of services by clinical commissioning groups for the problem. So there are under-trained staff, a lack of suitable dressings and bandages, and really a drop in the numbers of district nurses, as you know, and sometimes it's very difficult if you district nurse has to help with the treatment of these wounds, and afterwards actually trying to help you to get a clinical stocking on top of the legs. I've got a friend who had something similar, and she told me she really couldn't, she lived on her own, she couldn't manage to put the elastic stocking on, and I asked her what she did. She said she went out in the street and asked passers-by to help her put the stocking on. Well, that's ridiculous. But I think the whole thing needs a good look at, proper resources given to the subject, and particularly when people who are homeless, who have leg wounds, it's bad enough for somebody with a roof over their heads. But if you're homeless and sleeping on the streets, it must be absolutely indescribable.
So my name is Dr. Jamal Geraghty. I'm a nurse by profession, and I've been nursing now for nearly 20 years. And for, I suppose, as early back as my nursing training, I've always had a particular interest in inclusion health. Wound care is no different than any other specialism in the medical nursing field, and it needs to be treated that way.
It's actually both legs. It's about 5 ulcers, and I've had them for about 7 or 8 years. Yeah, wound care should be treated like other things, because it's really important. Not being funny, without the wound care I got at CHIP, I wouldn't have any legs now. So basically, yeah, it should be. I've lost count of how many times I've been admitted to hospital with my leg ulcers. The last time I was in for 5 weeks. Yeah, I've been admitted quite a few times.
So one of the revolutionary papers that was published in 2015 by Julian Guest and co-authors was around the economic burden of wound care in the UK and the NHS. And on average, they estimated that £5 billion is the cost of managing wounds in the NHS and associated comorbidities to wounds. And that is comparable to obesity in the UK. I mean, that's absolutely incredible.
Absolutely superb. CHIP is one of the best clinics that you could ever go to. The nurses are brilliant and they're irreplaceable.
And what is it about the nurses that you find is irreplaceable?
They're just so down to earth. They don't judge you in any way whatsoever. You can be whatever you are, right? And they don't judge you. They just take you for who you are. I go to CHIP 3 times a week, Monday, Wednesdays, Fridays, and when I get them done, the feeling's unbelievable. As I said before, it's like that fresh bed feeling when you've been on the same sheet for a while and you change your sheets and the mattress and everything and you get on a new fresh bed. It's like that cosy feeling.
So an example of somebody that I saw was a gentleman in his late 80s who had never injected in the lower limb and had quite an active, healthy lifestyle, some mental health problems, and had been living in a hostel for a long time and living with these chronic ulcers for maybe 5 years. We had to sit down together and we worked as a team, and slowly, once that relationship built up and that trust, his wounds started to heal straight away. It was really, really incredible and life-changing.
Daily life living with my leg ulcer hasn't been easy. When I get up in the morning, I'm having to drink quite a bit of alcohol just to stand up because of the pain. When I go down to town, I get on the bus, people look at me, the smell is kind of not cool, and they take the piss. As my friend said, if it was a broken arm or a broken leg, they can see it. With an ulcer, you can't see it. They don't know what the smell is, they don't know where it's coming from, so they judge you on that.
Every individual is different, so you have to engage with that person on their own and address that. Well, no situation is the same. So one of the elephants in the room is pain. And that really needs to be explored in this group of people, because I'm under no doubt do they suffer with pain, sleeplessness, reduced mobility, burning. They've often told me it's like shark bites, bee stings, stabbing. These are some of the terminology, wanting to cut their leg off. So how can you say that person is not in pain?
The hardest part of the leg ulcers was the stigma attached to it. The shit I get off it, the people taking the mick, the smell, the getting into somewhere to live. Yeah, that's the hardest part. Yeah, I've been kicked out of hostels because of non-compliance with appointments and my leg smelling, other residents complaining. Then I've had problems getting into another hostel because of that on the perf, of the fact of the smell. So yeah, it's caused a lot of problems. It just hurts, you know what I mean, when people come out with crap like that. It hurts inside, like, because you're a person, whether you've got a wound or not, yeah? You're still a person, and it doesn't really matter what you've got wrong with you. People should accept you for who you are. So yeah.
Hi, hello. Okay, so we've had some really powerful, footage there, and an account from both Anne and Ian, and I'm sure you'll all agree. It's sort of very emotional when you're sort of looking at the reality of what people are suffering with on a day-to-day basis. So I'm Jasmine Malik. My background is I'm a GP. My specialist interest in homeless health and inclusion health. I'm also clinical lead for North Central London for homeless health and mental health. So I'll be talking today in respect of the actual general need for specialist services, such as for addressing wound care specifically for the homeless, the risk to the patients, to the people if we're not getting this right, and then the overall cost that we can really see on the NHS as a consequence of not getting it right. Next slides, please, Casey. Thank you. So in terms of what we really know, I mean, we know that ulcers, we all know that they're extremely debilitating. They greatly reduce a person's quality of life. In terms of the stages of healing, with wounds that are existing for any period of time, there's a normal healing process which takes you through the inflammatory phase, epithelialization phase, and the maturation phase. And the wounds which are considered chronic are those which have not gone through the normal timely manner of healing process, which is if it's beyond a 4 to 6 a week period of time, then it's considered to be a chronic wound. And chronic wounds really sit in the inflammatory phase. And it's likely that, in cases with regards to homelessness, that they're sitting in that period of time for weeks, months, years, and even in some cases, decades. As we know, in terms of, there's a lot of factors that affect healing in general. And we've got to understand that in somebody who is homeless, they've got additional compounding factors which really affect the ability to heal. Not having that permanent base to have as home, not having abilities to wash and manage general self-care really do impact on the ability to maintain general cleanliness around the wound site itself. As we know, we are what we eat, and in general, what we find is that people have generally poor diets and nutrition as a result of the situations that surrounding homelessness. The other aspect is that there are significant barriers that we all know about that in terms of engagement for people who are homeless and accessing just normal mainstream services. The other thing to bear in mind is also, even though there may be some versions of services available, it's not necessarily the correct service, and it may be an inadequate assessment, and treatment choices are chosen, and the path to recovery is unnecessarily extended. Next slide, please. So in terms of the cause of leg ulcers, now I don't know if There we go. I've cleared the screen. So you can see there's a table on the right-hand corner here in relation to the underlying causes of leg ulcers. In general, what you see is there's approximately 80% of ulcers are caused by venous insufficiency. So they're deemed as venous ulcers. The other common causes are arterial disease and neuropathy. And in respect of less common causes, it's related to metabolic, hematological trauma, tumours, and also infection. Next point, please. So in terms of really, as we're sort of saying here, it's really important to identify the underlying cause of the actual ulcer in order to be able to put appropriate management in place. If we don't do that, then we're just literally seeing something, putting a plaster on it, and in reality, we're not actually solving the issue, and it's prolonged extensively. Just a question to the clinicians in the audience, and just as a consideration really and reflection, just out of the patients that you may have seen with lower limb wounds, how many have been referred and seen by a specialist, vascular specialist, to determine the underlying diagnosis? Okay, next slide. Thank you. Okay, so I mean, now we really come on to the sort of the issues around morbidity and mortality and the general risk if we're really sort of continuing to not address the issues that we know as clinicians are out there. What we know is that homelessness and poor health is intrinsically linked with the poorest health outcomes seen in society. We know that the average age of death in men is 45 and 43 for women. It's, that in itself is really, it's quite a shocking facts and statistics. People who are experiencing homelessness are less likely to be able to access and engage in healthcare services. And in terms of the barriers, the structure of the traditional healthcare services, it's really challenging for people who are homeless to being able to really sort of attend these, and it doesn't necessarily meet the needs of this population. As a result, and consequently, then we're finding that there's a significant proportion of people attending A&E, and there's going to be admissions as a result of that. It leads into the revolving hospital door situation where they're really not addressing the underlying issues and the longer term management. We all know that untreated wounds then can lead to significant other significant health issues, and it's really important to keep in mind. And currently, there are so few services which are designed specifically for the homeless to treat and target leg ulcers. In terms of the possible long-term consequences, we've already heard, from the video, we've seen Ian's situation, and we've also heard from Anne's account as well. Pain is a significant thing here, and it's really, really impacts on a person's life. The psychosocial impact, the sort of the social isolation that as a result of, not being sort of welcomed on buses or the waiting room clearing, these things are real and really impact a person's quality of life. As a consequence of the long-term changes, you'll find sort of the skin also starts to reflect the changes in that. So the skin patterns are changing, and then you get peripheral edema, so swelling to the lower limb, which in itself adds problems and pain and discomfort as well. And in terms of infection, obviously we know about local infection. There's sort of like a cellulitic picture. Then there's also to think about the underlying infections to osteomyelitis, infection of the bone, and the systemic impact of septicemia as well. There is a risk, if left unchecked and unmanaged, that there's a potential of malignant degeneration as well. So it's really mindful that, these things which people have been living with for, as I said, up to decades, it really is important to keep an eye on the potential changes being seen. And as Alison mentioned before, she's got clients who've had amputations. So we have gangrene and amputation, things that lead up to, sort of, again, another significant impact on general daily life. One of the other things I really wanted to point out here is that it's less known, but there is a link between amyloid A amyloidosis and the long-term picture of the chronic inflammation that's seen with leg wounds. Now, what we'll see is that it really presents itself as a renal complication. And it's for my clinicians on the call here, it may be worth considering having a look through the list of people who may have some renal complication, renal issues, and correlating to see if there is any past history of long-term inflammation in the past. The other aspect here is obviously death. Death related to wounds can be direct or it can be indirect from any of these absolutely debilitating conditions. Next slide, please. Okay, so coming onto the costs. Now, I mean, the stats and data, which were sort of discussed by Jamel in the film, this was a study a cohort study evaluating the burden of wounds in the UK. Now, the data that they were potentially discussing was from 2013 to 12 to 13. There's been a further update from 2017 to 18. Now, in that, what's come about in terms of between the two study dates, the annual prevalence of wounds has actually increased by 71%. And it's estimated now that it's about 3.8 million patients with a wound which are being managed by the NHS. And consequently, because of this, the cost now is in the £8.3 billion per year. Now, that is divided into sort of those wounds which are healed and also those who are unhealed at this time. Also to note that actually 81% of the total annual costs they're actually occurring within the community. And bearing in mind, sort of in terms of, if you look at the table on the right, you can sort of see the distribution of the workload and the cost impact from district nurses, from healthcare assistants, and also on practice nurses. We have to bear in mind also that actually there is, so in terms of this specific data and the cost, we have very little information in relation to that of those people who are facing homelessness, and in terms of the cost of the wound care services specifically for them. Okay, next slide, please, Katie. So this table is basically a graph showing the admissions by practice in the Camden region. So my background in homeless healthcare has been within the Camden area mainly, and as you can expect, the practice names have been anonymised, so they've been removed for obvious reasons. But I can say, in terms of the practice on the left, which is the first column on the left, that actually reflects the homeless practice which is in Camden. So what you can see here, between the years 2018 to 19, the proportion of practice admissions are significantly higher in the homeless practice. Now, in terms of unavoidable admissions, in respect of that is a significantly higher proportion of unavoidable admissions. But in terms of those which are avoidable, we really have that proportion is significantly higher as well. And you can see, in comparison to the other practices across the whole of the borough, really the homeless practice really stands out. So just moving to the next slide, please. So what I did when I sort of saw that and could sort of see that, in terms of there are a significant of admission avoidances that we could potentially look at and trying to address, it was to sort of delve down and have a look at the background to the avoidable admissions. So this is a list of the 10 most common avoidable admissions to hospital. And this was in the period of just for the month of March 2019. One thing we have to kind of sort of say here is at the moment, hospital coding is not necessary, it's not consistent throughout. So what we're finding is that so various soft tissue injuries or wounds or and general wound care, if there's underlying DVTs and various things are being broadly categorized as cellulitis of other parts of limb. It does really indicate that we need to do a little bit more sort of concentrated work and sort of delving down into the data to specifically identify, which people are falling under which categories. Is it that they are homeless? The previous graph indicates that there's most likely that a high proportion of those people are homeless. However, in terms of actually having that data sort of available, really, we need to do a deep delve in regards to that. But taking into consideration these avoidable admissions during the month of March, what was deemed as there were 9 avoidable admissions in the Camden area. 58 bed days were taken up from these admissions, and the overall cost for for those 9 admissions was £50,000. And when you put that into context, in sort of in respect of the amount of cost, that's just for an avoidable admission. It really is. We need to think about things in the community. Okay, next slide, please. Okay, so I mean, in terms of that and the background, as clinicians, you will all know that this is a need which has been shouting out for decades that we need to address. And having some form of data that we could look at and sort of discuss, it was an opportunity which was taken to, there was funding opportunities which came available, and it was a chance for that to be taken through and discussed to address the physical health needs of the homeless population. And sort of it was at the Camden Homeless Health and Care Network, we had a mix of non-clinicians and clinicians and discussed sort of the various aspects of things which we could potentially utilise the source of funding. Then FLIC, as the people who are presenting and sort of accommodating us here today, they had £70,000 that they could put towards this, and then also Public Health Camden had been, sort of had placed a bid for Sections 106 monies, and funding was funded a sum of £55,000, again specifically targeted to managing the physical healthcare needs of the homeless. Next slide, thanks. So as things developed, we did a closer sort of a gap analysis with the teams around the Homeless Health and Care Network, and through this, what was found was that what was felt lacking within the borough was that there was very little outreach type of nursing for the homeless population specifically, but also in terms of the limited specialist wound care services for the homeless in the borough as well. So 2 pilot projects evolved as a result, and it was supported by 2 separate working groups. Because of the nature of the 2 pilots, although they worked independently, they did work alongside each other and sort of fed into each other in terms of cases and referrals, etc. Next slide, please. So the base of the pilot project took place at Camden Health Improvement Practice, CHIP. That's the homeless practice in Camden. And in terms of, although we were very, very lucky in the past to have Jamel, the tissue viability specialist nurse, coming voluntarily on a monthly basis, historically, there was no tissue viability specialist nurse-led clinic in the whole of London, specifically aimed for the homeless population. So in terms of how things went, so the duration of the projects was held within CHIP, and this was CHIP whilst it was under Turning Point. CHIP provided nursing input for both the services, the outreach nursing and also tissue viability specialist nurse-led wound care service, GP supervision, the clinical room, the equipment and the space, and in terms of admin support as well. And one of the things that, because of public health funding, was a purpose to serve the whole of the south wards of the borough, it was possible to open the service up for referrals from GP practices in the south of the borough. Next slide, please. So, as we will be hearing later, a bit more in detail in terms of the actual pilot study from Jamel, I just wanted to leave you with a couple of quotes that sort of came through as the pilot project was kind of running. And it really sort of kind of hits home for you in terms of the amounts of times that people get admitted to hospital and how sort of in terms of what they're having to manage in respect of when they are in hospital and they feel that they're just not necessarily, they feel there's sort of social isolation, the stigma is attached to it, people feeling that the hospital nurses may not feel that they want to touch them, the impact that that has on them. And then in terms of the feedback that we really got from clients in terms of the service at CHIP, I think we've got this one last quote down here about saying how down to earth the nurses are, how they don't judge you, and they generally just make you feel welcome. And it really is important to sort of have that kind of empathic sort of view and sort of engagement with your clients. So I'm going to hand over now to Debbie Holt. She's Assistant Director of Integrated Commissioning for Camden CCG. Debbie, are you there?
Yes. Sorry, I'm just trying to put my video on. I hope you can hear me.
Yeah, we can hear you.
Tell me I can't put my video on. I'll just proceed. I'll try to turn my video on, but it doesn't seem to be allowing me. So I'll just continue with the presentation if that's okay, because you can hear me.
Sure.
So thanks for the introduction. I'm Deborah Holt, Assistant Director for Integrated Commissioning in Camden. And I guess I've been asked to talk to you about the kind of commissioning approach to homelessness and particularly in relation to some of the physical health needs of people. If we can move to the next slide. So apologies if we have lots of commissioners on the call today, but I just thought I'd kind of give you a bit of an overview of what a commissioner does, because we often get asked the question about what our role is. So essentially it's just to buy services to meet the needs of a population, and we tend to do this by using the kind of evidence of need. So things like joint strategic need assessments that get done every year or so gives us a kind of overview of what the needs of our population is. We talk to service users and the public about what they feel they need in their particular area. And of course, we use clinical evidence to kind of to back up the services that we commission, and NICE guidance, etc., are all part of that. The challenge, of course, is that, you know, we have to do what we do within a defined financial envelope, and there's always more demand than capacity. So we do often make decisions that can be quite difficult, and you know, so not always an easy job to do when you feel very passionate about the kind of populations that you serve. Next slide, please. I mean, Jasmine's touched on the kind of health inequalities with homelessness, so I kind of won't delve into too much, but there's, you know, an abundance of research that kind of demonstrates the kind of health inequalities for homeless people, and COVID has certainly kind of shown a lot more on that. You've heard about the life expectancy for men and women. In London in 2018, there were 726 recorded deaths of homeless people. 20% of those were in London, and at least a third of them were the result of treatable medical conditions. So it kind of gives you a flavour of there's just so much more that we can do. And also, homeless people are 4 times more likely to use emergency services than the general population. And that's generally because the services that we have commissioned, mainstream services, are not always accessible and responsive to the needs of our homeless population. I think one of the things that has really kind of has highlighted for me in the past 12 months around COVID is actually what we can achieve when we put our organisational boundaries to one side. And it was really exemplified in the pandemic and throughout the last 12 months, because the work that we've been able to do together has been astonishing. So we can do things differently, we can do things better. Next slide, please. And this slide just really kind of gives some data to the point that I've just been making about the kind of health inequalities, and I'm sure a lot of you are familiar with this, but more than 60% of homeless people have a history of substance misuse, significant mental health in this population, with around 70% of people reaching the criteria for personality disorder, which is essentially a lot of people's trauma comes from childhood, and a lot of people who need mental health support cannot access it in the way that they should. More than 80% of people with at least one health problem, and 20% of people with 3 or more health problems. So I'm sure that's not news to many of you, but it really does highlight the kind of health inequalities for people. Next slide, please. So just a bit about Camden. So historically, we have had a really high prevalence of homelessness in our borough, and it's more than likely to be the result of the fact that where we're situated, So we've got St Pancras, Euston, and 3 major transport hubs in our area, in our borough. And we have the second highest prevalence of rough sleeping in London. When you look at the data for this year, we've had 250 people asleep in since the beginning of COVID. And despite the fact that the Everyone In initiative from the government has been really helpful, we still have 35 people around sleeping rough on the streets, with an average 10 new people coming every week. We have 675 beds in our hostel pathway, and we have 1,900 people in temporary accommodation. So it kind of gives you a bit of a flavour of the prevalence of homelessness in our borough, using that kind of broader definition of what homelessness is. Next slide, please. At the beginning of the pandemic last year, Public Health did a very rapid needs assessment of our homeless population, really just to try and help us plan how we respond to the pandemic. And these figures here, I won't go through them, they're pretty much what I've described in terms of the national health inequalities. But you can see that mental health, drug abuse, physical long-term conditions, respiratory diseases are all very much prevalent in our Camden population, like they are nationally across the UK. Next slide, please. So in terms of Camden's provision, like I said before, we've been commissioning homeless services for a very long time, because we've always had a high prevalence of homeless population, and we've got a really good range of services that we've commissioned. Jasmine's talked about the dedicated primary care practice, which is CHIP. We have a dedicated mental health outreach team, which is Focus. We have local commission contracts with GPs for homeless health services, peer support services, FLIC and other work that they've been doing. Lots of services within the council, doing outreach teams, and a plethora of ad hoc provision that we've commissioned over the years, which often comes from short-term funding. We do some great initiatives, have some great projects. Sustaining that has always been a problem. So that for me is one of the key challenges. I think there is definitely more work needed, and there's more services that we need to do and improve the access for our clients that experience multiple disadvantage. And also, access to wound care for homeless clients has been very challenging, with small pots of money to do little pieces of good pieces of work. But again, we need to think about sustainability of that going forward. Next slide, please. Some of our key challenges, and I really like the phrase at the top. I think it's really useful when we talk about a team for everybody but a place for no one. And what we really mean by that is we have lots of services. We have mental health services, we have personality disorder services, we have substance misuse services, we have all kinds of different services. But there's lots of those teams are out there, but there kind of isn't a place for no one, because this particular population really struggles to access those services, despite them being commissioned. Again, the specialist care that we need, access and tissue viability treatment for homeless people, has been a challenge. The fact that people don't meet thresholds for services. We're not necessarily commissioned services, particularly around mental health, for people who need some kind of trauma informed practice. We very much have those kind of really high levels of thresholds that people just cannot meet, and also they're not, homeless people, very unlikely to engage in that really structured treatment. So there needs to be a very different approach to that. And things like demand and capacity, austerity and financial constraints that we're living through, and that the public sector going through massive reductions in funding over the years. And so we're constantly really almost like chasing our tail, trying to chase funding to put in services, but ones that are really helpful for this population, and we can actually sustain them going forward. The short-term funding is great, but we need something that's more sustainable and long-term. Next, thank you. So for us, what reflecting on the last 12 months and all the good work that we've actually done, what for us needs to change is that what we need to have is our services that we do have. we need to kind of bring them all together in an integrated way. And we know we can do this because we've done it through COVID, but actually have that more outreach offer to people. So we expect people to come to mainstream services, but actually that doesn't work for this population. So we really need a more clear focus on outreach and proactive services where we can take those services to the population. Our pathways need to be simpler and more rapid. The coordination of our clinical interventions to maximise the use of our resources. And we've really seen how we can do that effectively through COVID. Social care act assessments are really important, you know, particularly we've got people who have been homeless for a long time, but that might now be going into care homes at a much younger age than they probably should do, and not really having the access to the services, the social care services that they need. So we've really got to get better at doing that. And I think when we look at all of the contracts that we commission, they're all quite siloed. And I think for us to have some really significant systemic change, we need to do something more beyond tweaking current contracts. And I think we've got opportunities to do that going forward. And in Camden, you know, the political appetite for improving services to homeless people is tremendous. And we've got lots of backing by the leader of the council, the chief exec, and you know, they've really been pushing for us to put in proper services for this group. Just learning from COVID, I know lots of areas did some fantastic work across the country, but I think for us it really showed us how local authority and NHS commissioners can develop an integrated model that works really, really well for homeless people. And we did this in a COVID Protect hotel we set up in Camden, which is the Britannia Hotel, which housed people who were high risk due to either their physical health problems or their age, and they needed to be able to self-isolate if they was to catch COVID. And so we kind of set up this service. We put a team around it, which consisted of nurses, doctors, OTs, dentists, the whole gamut of organisations, and it worked really well. And we're kind of learning from the lessons that we've taken from that and now started to commission service in a bit of a different way. The FLIC wound care and nurse outreach pilots really demonstrates how a flexible model can work and how it can engage with people in the community to bring them to access treatment, and highlighted the need for greater integration and outreach across our system. Again, something else that we really need to consider going forward. And we've got really good learning from some of these pilots that we've done, and we shouldn't lose that and take it forward with us. Next slide, please. So where next for us? We've already evaluated some of the work that we did as part of COVID, and we're going to be using that to plan our services going forward. We're going to review the findings from the wound care and outreach pilots, which Jasmine's just talked to you about, to inform how we commission that going forward across North Central London. And really we're kind of moving into a space now where we're talking about integrated care systems, and that really gives us an opportunity to think differently about how we commission and deliver services. So that's quite an exciting and timely time for us in terms of what we're doing around homelessness. And our plan is to kind of develop a case for change this year, which really pulls all that work together and commissions a really joined up and integrated service for homeless people. Next slide. I think I might have done that. I'm done. Thank you.
Many thanks, Deborah, for that insightful presentation. That's been really great. Thank you so much. Hello, everyone. My name is Jamel Geraghty, and I'm a nurse consultant in tissue viability and lecturer at King's College London. And I'm going to start my presentation by introducing a video and a discussion with one of the vascular consultants at St. Thomas's, Mr. Luc Labiasi. And I think it's really unique and novel to have the voice of a consultant vascular surgeon within this presentation. So many thanks to Mr. Biasi for sharing his expertise with us. Next slide, please.
Well, Jamal, my name is Luca Biasi. I'm a endovascular consultant at St. Thomas's Hospital and King's Health Partners. And I'm also co-director of the Ad Integrum Vascular Wound Care, which is a private enterprise treating patients with a complex lower limb condition. And actually my area of expertise is a complex arterial revascularization in a patient that are presenting with critical limb ischemia.
And tell us a little bit about your involvement or your experience of working with patients who have experienced homelessness, who your department or who you may have seen in the A&E department with lower limb problems. What's your kind of experience around that?
Well, working in a London hospital based here at Westminster, we often meet patients that come presenting with emergency situations, and most of the time as a consequence of their living roughly on the street or experiencing homelessness, mainly presenting with lower limb conditions in the forms of either severely complicated wounds, leg ulcerations, and sometimes with arterial complication, especially if they are experiencing actively injecting drugs. As you know very well, living homeless in situation expose people to the risk of developing chronic venous insufficiency and venous hypertension. This is not only a condition strictly related to injecting, but is an inevitable situation of prolonged immobilization or being not having access to appropriate health care and medical advice. Well, it is clear that these people they present to A&E only if they are really desperate. So unfortunately, there is not enough knowledge and culture within healthcare professionals to approach correctly these people. There are often some misunderstandings and misconceptions. I would say that the stigma upon this population is huge. And I've learned a lot, especially from your studies, that there is not only a perceived stigma, but there is an attached stigma that we as a healthcare professionals give to these patients. And we often relate to them as they are potentially non-reliable and non-compliant to our advice. But on the contrary, I think they are very streetwise. They do really understand their own condition. They have quite accurate knowledge of their anatomy and their situation. But they feel very protective, and that this barrier that there is between them and us is often misunderstood.
Yeah, I think I agree completely, and I think there's a fear element there. And you know, they are maybe from previous poor experiences, from what my study has told me, from unfortunately our shame, I suppose, from clinicians, that they've experienced some form of prejudice.
So we know that in the general population, having a non-treated venous leg ulcer, that comes with the risk of deterioration, the risk of developing severe infections leading to sepsis, and in very selected patients, the risk is even of a limb loss. We need to understand that venous-related ulcer may lead sometimes to a gangrene, to a venous gangrene, to an amputation. It's not just a matter of arterial ulceration. So neglected ulcers, they are a huge risk for the person itself. And of course, non-healing ulcers are a huge burden on the national healthcare. We know from the guest report that this is a burden on the general population, not to say about the vulnerable people. The recurrence of ulcerations in the normal population in a 5 to 10 years period is more than 30%, despite appropriate treatment, compression, and despite ablation. So for the homeless, where we normally do not offer surgery because they are difficult, harder to reach a population, and we are also in a difficult situation in terms of following them up after the surgery.
So I'm gonna stop you there because that's quite controversial, in the sense that I suppose we have called them difficult in terms of difficult to operate, difficult to engage with them, difficult to follow them up, and I suppose we need to do better. I think very much from what you've just said is the culture around how this group of people are viewed and how we need to see them in secondary care for specialist services such as vascular. So what would you like to see change? What would you like to see happen?
Yeah, first of all, when I mentioned the difficulties, those were the difficulties of our system from our point of view. So those are the limits and the difficulties of the NHS that is many times unable to cope outside the usual standards, outside the current practice. So that's a difficulty of the system, not of the person. So I think that's the challenge, to work outside the boundaries of ordinary practice. I think, as you know very well, because that's what you also have highlighted from your studies, the key to approach these people is to have the flexibility and the understanding and the time to listen to their story and to understand their situation and to gain their trust. Once that is gained, they're not a difficult population at all. On the contrary, they are more engaging than probably the average person. So that's the challenge for the NHS, to work outside the box, outside the standard boundaries. And it is a challenge. We as physicians, we are not often prepared to, we don't have the tools, the psychological tools to relate to people that we don't probably understand fully. Is often we just rely on our personal ethics and personal way of thinking. There's no one that will teach you as a nurse or as a doctor how to behave in these circumstances. So that's something that we need to do better. We need to have the expertise. It's not just medical or nursing expertise. As you know, I'm strongly supporting the idea that vascular services should join the homeless services and the tissue viability expertise, because these patients need specialist care. They need it from a nursing perspective, but they need it, like, for example, tissue expert, tissue viability support, but they need it also from a surgical vascular point of view. They are facing situations where a timely vascular assessment can be a life-saving approach. I've been on call over the weekend here at St. Thomas's, and we had a couple of situations where these patients were at risks because of presenting either with groin infections or pseudoaneurysms. Infections that, if not treated timely, could lead to life-threatening sepsis. And the outcome are often dramatic, either limb loss, risk for life, or infections that do not resolve. And there are huge difficulties to carry on this support after the emergency care. For example, having patients with DVTs and infection requiring long-term anticoagulation or long-term IV antibiotics is often difficult to achieve in the community. Once the patients once the patient leave the hospital, there are no infrastructures to continue the care in the community. So often the life-saving treatment that we can offer in the emergency tertiary referral center may be lost when the patient is leaving hospital, leading to recurrences and leading to very dangerous situation.
Many thanks to Mr. Biasi for taking the time out after his busy on-call to share with us his experience working directly with homeless patients. So I'm going to begin by talking a little bit about my journey into homeless and inclusion health. And I suppose it began really in 2012, 2013, when I was based at the Royal Free Hospital as a tissue viability nurse and remained there for 12 years. And during that time, I was leading the vascular leg ulcer clinics alongside the vascular team. And quickly I noticed a steady trickle of patients that were coming into the vascular clinic who were either experiencing homelessness directly or who were actively injecting in the lower limb or had previously injected, and they had terrible wounds. I mean, ulcers for many, many years. So by linking in and finding out where these people were going, where was their GP practice, I was able to establish links with Chip and with the wonderful nursing team there, Maggie and Eileen. And we quickly established a good working relationship. And back in 2012, 2013, I was visiting Chip, I suppose, quarterly, voluntarily. And the whole aim was to do, lower limb assessments, Doppler, ABPI, instigate compression therapy, which is the gold standard for venous leg ulceration, try and stop people coming into hospital, and to see patients where they wanted to be seen and were comfortable to do so, which was at Chip. So it worked really, really well. And then I would say probably in the recent years, I was actually going there every second month and then every month. So it was a fantastic initiative, and that kind of linked me in with Jasmine and the team there. And one of the reasons I jumped at becoming part of the pilot, because I believed we could make a huge difference, just not only locally, but nationally as well. I'd also like to mention that I'm part and have been part of the Homeless Health Network, Nurses and Midwives in London for many years, and I've presented at their amazing conference here. I know the team, Kendra, Sam and Chris really well. And we're doing some exciting work as well in relation to wound care this year and with the Q&I, so do watch this space for that. So I suppose with my other hat on, my research hat, it's important to mention that for 7 years, while I was working as a tissue viability nurse, I was also undertaking a qualitative study as part of my doctorate in health research. And that study was looking at the narratives of people who had a history of injecting, living with leg ulceration. And even though I had an idea what this looked like on the clinical side, it wasn't until I collected the stories of this group of people through their diaries and their interviews that it really kind of, resonated with me, the suffering that they were experiencing living with these chronic wounds. And here's an example of a lady who took part in my study, and she drew her leg ulcer, and she talks about having to self-care for her wound and missing her appointment, and how she will get to the GP the next time. Next slide, please. Here is another example of my research, and this actually was a lady who completed this, who drew her leg ulcers. She was married for 30 years, and both her and her husband actually took part in this study, and they talk about, you know, the difficulties of living with leg ulcers, how they felt like lepers, how they felt at the mercy of their GP. These are their words, and what it really highlighted to me was the incredible pain, not just physically but psychologically, and the shame and the stigma that this group of people were living with, not to mention the pain of their wounds also. The study also demonstrated the impact on identity. And I think this is important because people who live with chronic wounds, you know, over a long period of time, it does become in a way part of their personality, in the sense that, like anybody living with any chronic condition, they can become quite fixated on it. And with this particular group of people, it can have quite a negative impact on their mental health, having to live with the wound and, you know, the challenges that exist around that. We know that chronic leg ulceration causes isolation and depression and loneliness, but we're not fully sure in terms of the impact on relationships. And one of the things that my study told me was in terms of intimacy and affection, and having seen patients who had ulcers for many, many years and were in relationships, often their partners had never seen their wounds. So again, there needs to be a bit more work in terms of the impact on relationships and intimacy. One of the amazing things the study told me, and that the participants shared, was that those who attended specialist wound clinics, those that had that oversight of tissue viability, they reported significant positive engagement and concordance, which in turn, of course, improved the healing of their wounds. And of course, in turn, their quality of life. Next slide, please. These are some of the things that patients have told us, you know, and going back to Ian's story of, you know, public transport. And it's a really real dilemma, I think, that they face in terms of not being able to get on a bus or being asked to get off a bus because their wounds are smelling. You know, this group of people are walking around often for hours on end every day with these leg ulcers. The stigma that is attached to them, and again, it's about the difficulties of housing this group of people because of sometimes the significant malodor that exists when you're living with a chronic wound. But I think it's important to also note the positives within this. So when people are in contact with specialist services, it's like anything. You know, we have specialist input for dentistry, sexual health, podiatry, and wound care is no different, even though it's seen as a general nursing skill. And there is that extra level of expertise within vascular and wound care that certainly makes a huge difference. And, you know, patients tell us that they start to feel more like themselves. They feel like they're getting their life back, but they also recognize that level of expertise when you sit them down and you go through it with a fine tooth comb. They really do appreciate that. So just to let you know that the next few slides will have pictures of wounds. And like Alison said at the beginning, you know, this has remained very hidden for far too long. And, you know, as much and all as it may be uncomfortable for people to look at, I suppose our discomfort can't be their suffering. And I feel very, very strongly that we need to get out there and talk more about this, because one of my hopes is that in the future, no homeless person should have to live with a chronic wound, because they are absolutely treatable. Venous leg ulcers are healable and certainly preventable in a lot of cases. So the next slide, please. And I suppose those of us sitting here, you know, we're here, we've got our foot and leg health, something we probably take very much for granted. But if you're experiencing homelessness, and certainly if you are street homeless, you know, you rely a lot on your legs and feet and the health of your legs and feet to get around. And I think try and imagine yourself just for a few minutes in, you know, extremes of weather, whether that be rain or cold, and having to wear your footwear if you're lucky enough to have footwear, which, you know, we have seen instances with patients coming in with no footwear in the clinic. And I think another element is that this group of people have to walk miles and miles and miles every day, and they need their legs and feet to get around. But also I've put here to protect themselves in the sense of, you know, sometimes there is a danger element there and they need to get away quickly. So for something that we may take for granted, they very much rely on them. And of course, wounds and ulceration, trench foot can lead to pain, lack of sleep, appetite, low mood and fatigue. And it's really quite draining. And I have seen when I was working in the clinic, patients coming in, not having their shoes removed for 2 weeks, and the absolute agony of that, and having to drink, you know, actively while we are looking at their feet because they can't suffer the pain of it. And ultimately, of course, as we've all spoken about here today, ultimately poor foot and leg health can result in hospital admission and, in the worst case scenario, amputation. Next slide, please. So these are an example of some of the gentlemen that I've cared for over the years. The first two gentlemen have venous leg ulcers. For those of us who have that vascular background, you can quite clearly see that the first gentleman has venous staining or hemosiderin staining, that brown pigmentation. The second gentleman has some ankle flare, and when he stands up, you can actually see that he has varicose veins. Both these two gentlemen have unfortunately passed away since these photographs were taken, but they always felt very strongly about their story being shared. And actually, I have to say, the gentleman in the middle, he would want me to tell you that I developed my great passion for Pink Floyd. He introduced me to the whole thing, so I have him to thank for that. And I suppose following on from that is very much the relationship that we have with these patients. And I knew both these gentlemen right up until they passed away. And what I can tell you is that I did treat their wounds and successfully, and they healed. Unfortunately, they passed away with complications from their liver cirrhosis. But contrary to what you might think about these wounds, yes, they are locally infected, but the patients are systemically well. And they were treated topically with an antimicrobial such as an iodine or a silver, and we reduced the bacteria burden with compression. The first gentleman actually had compression to the thigh. The gentleman on the far end, again, just to give you a little bit of vascular insight, that nice pink redness, there is an element of inflammation there, but actually this is an ischemic rubor, and this gentleman needed to see a vascular surgeon pretty quick because his limb is at risk. And again, this is where that underlying extra layer of expertise really does come into play. Next slide, please. So the clinic, getting back to the running of the clinic, it ran twice a week. And what I really wanted to do was not just capture patients with open ulcers, but also those who were at risk of ulceration. And what we used to try, and this is an example of a poster that was put up in the waiting room at CHIP, but also in the hostels, and it shows the CIAP venous classification down at the corner there. So we wanted to also capture patients who were presenting with any of these issues, such as swelling, redness, cramp or pain or walking, so not just purely venous. And of course, those patients who maybe had stopped injecting, one of the things I forgot to say was the previous two gentlemen hadn't injected for maybe over 10 years. So unfortunately, you can still develop venous leg ulceration after many, many years of stopping injecting. Next slide, please. This is the first two front covers of the referral form, just basic. There was another layer in terms of the vascular holistic assessment and Doppler. But what I was really interested to capture in the initial stages was the history around injecting. You know, how long do people inject for? Where did they inject? Were they still injecting? What did they inject? And also basic information in terms of scarring, because sometimes these scars and skin popping areas can break down. So this was just a very brief initial referral. And as I said, there was entries also on the main system within the GP practice. Next slide, please. I'm going to present 3 case studies, and they're all very different in terms of what patients were coming to see me with. This is the case of a 67-year-old gentleman who had a period of street homelessness. He used to walk 3-4 hours a day. I don't know how he managed to do it, honestly. And then at night, he would sleep with his legs down. Sometimes he would spend many, many hours on a bus. So he had this quite chronic dependent edema. But you can also see by looking at his legs, and this wasn't taken on the first appointment, but you can see by looking at his legs, venous eczema. There's also, you could argue, some contact dermatitis there because it's demarcated. But in terms of the CAP classification, remember the venous classification, he was classified as C5, having previous healed ulcers or skin breakdown. One of the key points to note, within 3 months, this gentleman had had 4 hospital admissions. And, you know, in terms of the impact on his quality of life, he had reduced mobility, he was at risk of falls, he was reduced sleep, but also he wasn't a very happy chap when he came to see me, because he was wondering, why do I keep ending up in A&E? What is going on? Tell me what's happening here. He had no idea that he had chronic venous hypertension. So that it was really quite successful. Next slide, please. So basically, what did I do? Did a full holistic assessment, Doppler, ABPI, which was in normal range, which meant I could instigate compression therapy. Did that immediately. And within a number of weeks, 2 to 3 weeks, his superficial wounds had healed, his skin condition had improved, the swelling had reduced, and then we ordered him compression hosiery. He was absolutely delighted. I think mainly because he finally had somebody tell him what was going on, and that actually this was his reason for multiple admissions. We could try and prevent this happening again. In terms of costs, well, you can see yourself, multiple admissions, antibiotic therapy, and all the dressing time and the dressings themselves. So yes, successful story there. Next slide, please. The next case is that of a 50-year-old gentleman who had a history of injecting in the lower limb and his chronic leg ulceration for 2 years. Important to note that I didn't look at just one leg. I always looked at both legs, both feet, and that would be one of my top tips here today. Always check both of everything. In terms of his CAP, he had on the right leg, as you can see, an active leg ulcer, but also on the left leg, even though the skin was intact, he had, in terms of venous classification, a C4 with venous eczema. So that leg also was at risk. Interestingly enough, when I was undertaking the Doppler, using the handheld Doppler for the ABPI and listening to the waveforms and the signals from the Doppler, I could hear, and it's something that you kind of get tuned into when you do a lot of Dopplers, an arrhythmia, so atrial fibrillation. And so we referred this gentleman on to cardiology, and he was seen and obviously treated for best therapy for his atrial fibrillation. In terms of costs, well, we have it here: dressing costs, nursing time, GP appointments, and potentially the associate risk and morbidity of his undiagnosed AF. Next slide, please. So he had compression therapy, his Doppler was in normal range, and the wound healed within 5 months. I think one of the other important things here is also his, atrial fibrillation that he was referred on to. And I think it's that, again, that extra level of expertise, that time, that conversation that really does add a significant positive result. Next slide, please. So this is another case. I've highlighted 19 years because you just think to yourself, how can somebody live with a leg ulcer for 19 years? It's just incredible. And when I met this gentleman, I just felt for him. I really did. 19 years ago, if you can imagine what happens, he was in a road traffic accident. He had a really bad break in his leg, and he ended up in an external fixator. And he was in hospital in those days, 20 years ago, for about over a year. The wound never healed. And he was currently living in a hostel. No history of injecting. He hated needles. Some recreational drug use. He was a smoker, hypertension, depression. He'd had so many different experiences of having his dressing changed by the time he got to me. So we really did have to work in that relationship, building on that trust. And then, we started the therapy. We did the Doppler, which was within normal range. But just very briefly, in terms of the cost, well, 19 years of dressings, 19 years of admissions for various things. And the cost to him, the pain, the malodorants, and the reduced mobility was really incredible. Next slide, please. So here you can see the wound within the first week of when he came to the clinic, and then slowly progressing. And again, to the final slide, which was 3 months. And I just think that's incredible. And he was just over the moon. Next slide, please. So other elements that were seen in the clinic, so venous leg ulceration, as you know, I also saw venous eczema and other skin-related conditions such as scabies and psoriasis. There were a number of self-harm related wounds to the lower limb, chronic groin abscesses and recurrent cellulitis, dependent swelling or edema. There was also patients who were amputees, and there were also pregnant women experiencing homelessness, living with symptomatic varicose veins. So just to give you, a full view of the clientele that was coming to the clinic. Next slide, please. Points to note about the clinic, and I think this is really, really important. So from the time that I started the clinic till the time it stopped, there were no hospital admissions for any wound complaints. The only hospital admission was that of a gentleman who was an amputee. We were worried he had a DVT in his other leg, so we needed him in, and it took a struggle to get him in, but we were glad in the end that he got in there. Other than that, there were no hospital admissions, no antibiotic prescriptions for wound care at all whatsoever, no recurrent cellulitis admission. All the patients engaged with the care. They came to their appointments, they used to enjoy coming to them, and they were committed. I used to enjoy seeing them too. So the success of the clinic was based on not just clinical skill, but it was on the relationship and trust that we had together. Alongside this, there was delivery of education. So there was education that was, I provided for hostel leads and also for practice nurses in the local area. They really got a lot out of it. And what I would say is some of them told me they hadn't had wound care training in years, which, I was quite shocked about. So they really appreciated that. During the duration of the clinic, which ran from August to March, there were 113 patient reviews, and 31 of these were new patients. There was also 13 hours of telephone advice given during the 8-month period, and this facilitated the engagement of clients and allowed timely arrangement of DNA appointments. I think it's important to say that there was always a positive atmosphere in the clinic. Patients were always welcome back. It was never, you DNA'd, you're not coming back and discharging you. Absolutely not. There was always that positive engagement. And sometimes, patients do test you because they've had bad experiences. They don't know if they trust you, and I can't blame them for that. So they could DNA simply just to see how you'd react to them. And I always found that used to make me smile because, I would have them back any day. And I think you need to have that flexibility and that mentality and ask, why is that person not coming to your appointment? Can they actually get to your clinic? Can they walk there? Have they got a phone? What are the barriers for them? Just put yourself in their shoes. So data was collected, and at the minute, we're in the process of writing this up for peer review. So I can't share the exact figures with you. But what I can say to you is that a number of healing outcomes were measured, and I can give you some patient demographic data to start with. So for example, 80% of the population that I saw were men, and the mean age was 50 years. 60% of the population that reviewed had a history of injecting. Past was 50% and actively was 10%, which actually wasn't a lot when you think about it. 70% had a previous hospital admission, and 27% of the population required vascular intervention. Unfortunately, but probably those of us on the call are not surprised by the next statistic, 70% reported previous poor care experience, which is huge. And then just moving on in terms of the Kaplan-Meier analysis at 90 days. And this demonstrated, again, this is generic because of our data being under peer review at the minute. Nearly all patients reported improvement in pain, level of exudate and smell. More than a third of patients were pain-free, and approximately half of patients were free of exudate, reported complete elimination of smell, and reported improvement of mobility and sleep. Next slide, please. So recommendations, this is extremely wordy, as you can imagine. But what we need to do is we need to have tissue viability, we need to have vascular specialist services linked in with homeless teams, ideally in primary care to a homeless GP practice. We need nurses who are trained in tissue viability and have a vascular leg ulcer training also to work alongside, if not in, homeless inclusion and health teams. The clinic needs to complement and coordinate the outreach system. And although outreach may address wound dressing, sometimes there isn't the time to do that holistic vascular assessment. We also need monthly MDT meetings, which involve A&E and vascular, and to look at frequent attenders for wound-related issues. These links and connections with local hospitals are essential in preventing avoidable admissions. Monthly virtual clinics to reach out to clients who choose not to or are unable to attend the clinic, and we need regular training days with support of industry. It is suggested that care navigator or hospital leads are also approached to establish if they wish to learn more about wound care prevention and management. I think this is absolutely key. And if they would be willing to do dressings with the oversight of a specialist nurse, thinking outside the box can assist with reaching out to people who would otherwise not engage. And as emerged from this experience, the majority of patients who attended the wound clinic were malnourished. And this obviously affected their wound healing along with their mood, their sleep, their mobility, their overall function and health. And going forward, we believe that alongside tissue viability, we need to link in with local dietetic services as a full integrated approach to this important aspect of care. And then lastly, we need a well-leg service. So as you've heard Mr. Biazzi say about reoccurrence, we need to make sure that once the wounds are healed on the lower limb, the patients have a safe place to go where they can have advice about skincare, advice about their hosiery, any worries that they have, some health promotion to prevent these terrible wounds coming back again. Next slide, please. Many thanks, everybody.
Sorry, on mute. Thanks, Jamel. That was absolutely fantastic. Really, really powerful presentations. And I think it really hits home, doesn't it? It's very hard to see looking at those wounds, but I think the reality is it's there. So just really to sort of sum up, I know we've got quite a few questions come through in the Q&A. So please keep putting your questions down in there if you want to address any of us on the panel. And just really, we've seen how challenging the situation is, the stigma that's really associated with people who have leg wounds, the social isolation, and the impact that when we're not addressing the issue, and these are going on for such long periods of time. I mean, it's heartbreaking to see that somebody's actually had to live with these for almost 20 years. So, yeah, I mean, I'm going to hand over now, I think, to questions. So, Alison, do you want to?
Yeah, thank you. And thank you for everyone who's put in some questions. We've got some really good ones here. So I think the first question that we have, sorry, my computer's decided to be temperamental, is do you have any tips to help patients tolerate compression more effectively? I think that's maybe one for you, Jamel.
Yeah, it's a good question. I mean, I'm quite controversial around how I look at things. And I think, we have to look at ourselves as part of the picture when we look at any therapy. And I think if compression certainly can be painful, but I mean this respectively, of course, we need to look at application, we need to look at tolerance, we need to look at what are the factors surrounding that person in terms of the pain. So do they experience pain even without compression? Maybe they are nervous about their compression, maybe they've had a poor experience from compression. My own experience of it is when patients come and see me, they do not want compression because they've had it and they don't like it. It's been sore, and it takes a lot of work to gain that trust so that they'll try it again. Then I start off, sometimes I just start off with washing their leg, putting a dressing on and getting them in a very simple bandage to say, look, is that all good? Now let's move to the next stage. I think with this particular group of people, sometimes we can't always get what we want straight away. We need to be patient and we need to really be guided by them. And once they see it work, and it does work, and we know compression works, even high compression, then you can move to the next stage. But I think sometimes we put them in, high compression straight away, and they have a fear already, maybe because of a poor experience. So sometimes, depending on the person, you just have to start, be patient, and then gradually build up. But we know it works.
Lovely, thank you, Jamel. And the next question, which I think may be one for you, Jasmine, is what skills and resources do you think GPs need to better address the needs of this client group?
So I think from the client group, we're talking broadly or in relation to wounds. I suppose in respect of, let's go broadly first of all. Obviously, one of the big issues that we're still facing, despite a lot of work being done to try and encourage that engagement with GPs, is that there's still the barriers around the registration process. So certainly is really important to kind of maybe consider and review the process in terms of that registration. In regards to actually allowing people to access primary care services in itself. So if you're having struggles with regards to that, I'm sure that the services, the groundswell services certainly have worked a lot in this respect to try and assist with regards to registration processes. There's several things with Healthy London Partnership. They've also worked alongside in terms of that registration process as well. Then the other thing to sort of bear in mind is in terms of it's often very daunting when somebody comes into a 10-minute slot and, you've got a multitude, you can just see it there. There's a multitude of health issues that kind of, how do you deal with that within 10 minutes? It's in reality, it's absolutely impossible. And it's really important to keep in mind that you have your anxieties as clinicians, sort of like kind of sat there, understanding that there is several medical things you need to address. But the key factor here is that they came to you for a reason. Look at what that reason was, address that reason. So keep in mind what you may, the list of things that may also need to be addressed. However, really sort of making sure that the consultation is kind of focused to the need of the individual. That will really help with the engagement side of things. The other thing is that, sometimes what happens then, you sort of send people out to kind of make the appointment for the future appointment dates, etc. It's often worthwhile checking in if somebody has a key worker, sort of any form of sort of assistance that could potentially help them engaging with the services. So just checking in with them. Do they have anybody that they could potentially work with and that they're happy for you to talk with and sort of assist with getting to the next appointments, etc. Then in terms of wound care, what we found really worked well in CHIP is, sort of obviously Jamel's fantastic service. And then on other days when Jamel wasn't there, it's like the other nurses are there. And if it's a case that somebody's on the couch and has their dressing sort of removed and it's time, it's just having that flexibility just to kind of step out at that point, just to kind of really engage with the patient as they're there in sort of in the middle of treatment, so that they don't have to go and come back or wait prolonged for further appointments. So it's actually quite a good opportunity to try and coordinate the times of the appointments. Does that agree?
That's lovely. Jamel, anything to add to that? Or?
No, I agree with what Jasmine said. It's very much working together. And as Jasmine said, when the GPs need to see the wounds, and that worked really, really well at CHIP. And we know it doesn't even work. It doesn't always happen even in general practice, that GPs have time to come into, but it's an absolute key part that they are involved as well in the wound care that they see, because you learn from each other. And I think, yeah, absolutely, totally agree.
Lovely, thank you. And a follow-on question from that is, did you face any difficulties with clients coming off pain relief that they might have been reliant upon?
So it's a huge area. As we've already spoken about pain, the impact that it has, and it's, the reality of that they have to live it with this day in, day out. And obviously, there's also the fact that many of clients have a sort of a history of drug misuse, and they may be taking various things or scripted on methadone. So it's extremely challenging to kind of, in terms of trying to get it right. And often what I found is that it's been really useful to kind of have the pain clinic teams on board with you and having a discussion with them. And if they are sort of scripted in on methadone, and then it's sort of also ensuring that there's linking in with regards to the people who are providing the script as well. Because if you're providing any particular additional pain relief, and it's potentially kind of, causing sort of, if it's interacting or causing compounding problems with what they're already being prescribed, or you don't know that they've had a change in dose, etc. We've got the concerns of potential overdoses or concerns you may have about sort of prescribing in the first place. So what I'd say in relation to this, it's respecting and understanding that there is pain, and that we do need to try and help and manage and maintain as much as possible a comfortable situation. I'd say get other clinicians involved, including substance misuse specialists, ensuring that they're not particularly, if they're on any particular prescribed drugs from them, or also the pain clinic as well. So sort of seeking certain advice as well in that respect. I know, obviously, with regards to pregabalin, with that now being a controlled drug, there is lots of challenges and lots of people coming in requesting pregabalin. Again, it's how to say this? I would say that we need to work together with other specialists who are sort of dealing with their care, because starting somebody on pregabalin potentially could, impact sort of issues of addiction sort of further on down the line and have further problems. But in respect of that, we also need to address the pain, and it may well be that you start them on something with a very clear plan and sort of outline in terms of the reduction, in terms of what the steps of management are, and that really encourages, hopefully, in terms of levels of engagement, having the wound care, addressing, and sort of getting them involved in a sort of a holistic, sort of all about round view.
Thank you, Jasmine. Jamel, anything to add to that?
No, the only thing I would just add to what Jasmine has said is just to kind of go back to what the results said from the patients that were coming to the clinic. 70% had pain, which is no surprise, but actually when the compression was started and instigated, a third of them were pain-free. So I think alongside what Jasmine is saying, also, give people hope. People who live with these wounds for a long time, they don't think they're going to heal. You're not the first person that they've ever seen. In fact, when I see them, they've seen people for years. So they don't really believe what you're telling them, that actually they can heal. You have to really get down and say, we can heal these for you. It's like when they hear that, it's this light bulb moment. It does affect how they feel in terms of the pain even. So I think, as Jasmine said, that holistic approach and that positivity, and you need to keep that up, definitely.
Lovely, thank you, Jamel. And a great question here from Sam Dorney-Smith. Would it be possible to set up a Pan-London service to send photographs of leg wounds in order to get some immediate advice? What do people think about that question?
I think it's absolutely fantastic. I mean, in terms of, there's so many challenges, isn't there? And sort of kind of looking at a local level is quite different to then looking at a regional level. And I mean, I wouldn't say that it's off the cards, but I think that there's several steps and stages in between before we're able to do that.
Yeah. I mean, just to add to that, I think having worked with vascular teams during COVID, when they've been doing a lot of their clinics virtually, I think it's certainly not impossible. Nothing is. I'm a great believer in that. I think you need expertise from GPs within homeless health. You need nurses. You need also the vascular input. If you've got a wound on your lower limb, it's not there for no reason. So this is another thing that, I could talk all day about. But if you have a leg ulcer, as Jasmine said, for more than 4 to 6 weeks, you have to have an underlying diagnosis. And as Mr. Biazzi rightly said, he's not seeing these people. So, there's definitely something missing there. And I think alongside an MDT group, it's absolutely doable. But yeah, it's a good question, Sam. Good question.
I don't know if Deborah, you want to come in on that, or if we've covered that.
I think it's a great idea. And as Jamel said, it's not insurmountable. So let's think about that as something going forward.
Fabulous, thank you. So another great question. So from Lisa, who says, we're struggling to source wound care training for our nurses and healthcare assistants in substance misuse services, and also for assertive outreach nurses. What would you recommend, please, as we don't want to do any harm, but want to help those we see in our services with non-healing wounds who may not be seen by other healthcare professionals? Great question.
I mean, there's a few things I can point you to straight away that's really helpful. We have a lower limb, as I say, I could talk all day about, there's a lower limb national campaign called Legs Matter. And that's a collaboration of not-for-profit organisations who are trying to promote leg and foot care here in the UK. So have a look at the Legs Matter site. They've got lots of information there in terms of what professionals need to look for and what patients. The other thing is, again, I haven't mentioned it because of time, but the National Wound Care Strategy for England has actually got lower limb recommendations that they've been working on for some time. They're out now. So again, go to the National Wound Care Strategy Programme and you'll find them there. I did mention myself and the Homeless Health Network, Sam and the team, we hope to put together a wound care document with the QNI, so the Queen's Nursing Institute, this year. So, you know, do link into the Homeless Health Network. I think you can subscribe to their email and also to the QNI as well. They've got an amazing homeless health program there. So we may not have exactly what you want now, but there are tools out there that can help. And as I say, hopefully later in the year, we'll be able to capture more of that. But you've also got my email, Lisa. I'm happy to have a chat with you. Just reach out, no problem.
And Jamel, there's just a quick comment there, but if you could mention the name of the website you just mentioned again there.
Yeah, so there's the Legs Matter campaign. Just pop in Legs Matter. It's got some amazing, and actually we have also a client that we know who shared his story recently, so some videos there. So Legs Matter, the National Wound Care Strategy and the QNI, they're amazing resources, but there's more to come. There's a lot more work to come.
Thank you. And another question, how can we encourage engagement and attendance? And I think this is an interesting question, thinking about engagement and attendance, not just with clients, but engagement with other services as well. So over to you guys.
So across, I know Camden and Islington, we have Groundswell, which is the peer advocate service, and it's been really useful to kind of link in with them. Actually, part of, so as I sort of mentioned in regards to, there were several arms to this study, and it sort of worked alongside the outreach nurse, but also at the same time, it was an opportunity for Groundswell to opt for funding from the HS2, so that it was a bit of funding from various pools, and we managed to obtain a care coordinator who was based at CHIP, and so was able to help link in with both the outreach nurse service and also with regards to Jamel's tissue viability service. So I mean, if that service is not, if that kind of service is not available for you, it's worth sort of checking in to see what other care navigation services you may be able to chip into. I know that Age UK is also another service that can potentially help with this population as well, and certainly worth sort of looking into that. And then, I mean, in terms of thinking outside the box of looking for funding opportunities to try and secure for a year or two sort of opportunities with regards to peer advocacy, that's also something worth considering. And then the other thing in terms of engagement as well, it's really, it's kind of making every contact count. And as I was saying before, in relation to sort of ensuring that, you know, when they come and see you in clinic, it may be about one matter, but if you're able to kind of deal with the several other things. So if they're sort of with the nurse, you know, popping in to sort of have a chat there, having your slots sort of allocated at the same time that they're potentially going to be there, that really just helps with that engagement as well.
Thank you. And I think we have time for one more question, which is what can be done during periods of lockdown? I think the answer is quite a lot, but it's not very easy. But over to you guys.
I mean, the only thing I would say, there has been a real focus around self-care, and it does absolutely have its place. But, you know, as I said before, I always try and look at two sides of the coin. And I think, as we've said before, look at the cost, look at these patients not having an underlying diagnosis. So if you are going to focus and promote self-care at a certain point in time, you need to follow that person back up, because what we don't want happening is COVID being kind of, you know, something else happening out of that in terms of patients not being forgotten, but things not being followed up. So certainly a lot of patients like to self-care, and I'm 100% supportive of that as long as the wound is healing. So if the wound isn't healing, then there is an issue, and that needs to be looked at. It's not that they self-care for 5 years and then somebody asks them, well, why have you still got that wound 5 years later? Well, I do my own dressings. Okay, that's a problem. So yes, self-care, it should be promoted, but there also needs to be that underlying diagnosis and that follow-up, because otherwise, then you have to go to the patient and you have to strip back why they're self-caring, and that in itself is a challenge. So it has its place, but it is in a very supportive way with this population, and actually with all patients with leg ulceration. They need the diagnosis, they need the support and the follow-up as well alongside that.
Absolutely. And then in terms of like currently with the sort of pictures of the lockdown that are happening, I know that the patients who potentially may have COVID symptoms, so they're self-isolating for a period. What I'd suggest is that for those who are on your list and then potentially having to self-isolate, it's having wound packs. So, you're able to be called and say, and provide some form of like just simple dressing so that they can do that self-care management. I know it's very challenging, obviously, in respect of the situation with lockdown. But I think, like as Jamel was saying, in reality, self-care is really, really important, but helping and ensuring that it's not just going to be self-care for years to come, and that we're really looking sort of at the underlying concerns and issues and helping them address it.
Thank you. I think that's all the time we have now for questions, but just to say, I know there's a few more questions still in the box, so we will be sending round written up answers to all of the questions, and also a copy of this recording. And like I said at the start, it's so amazing to see so many people. It's been an absolute pleasure, and we really hope that this is just the start of a national conversation about these issues, and we can take these forwards, do more of these events, and just make things so much more better. So I just want to say a massive thank you to our panelists, so to Anne and to Ian, to Joelle, Jasmine, Lukla, Debbie, and a massive thank you also to Katie, who pulled all of this together, who's been amazing. But most of all, to all of you for coming. It's been absolutely fantastic. Thank you so much. And we will be back in touch very soon. So lovely to see you all. Thank you. Bye.
Thanks, Alison.
Thanks, everyone.